Yeah, I'll share it momentarily. Yes. There you go.
Great. So thank you all for joining us this afternoon. I have a few center updates. If you haven't had a chance to see it, the Dunlevie Center website is up. It looks absolutely awesome. So much thanks to Anna and Giannina for their incredible work on this. It really has a lot of great energy, and I know Elizabeth and Bruce saw it and really liked it. Congratulations to Dr. Nguyen for submitting R01 and R03 proposals. You've been extremely busy, and that's a lot of work. We have good news regarding our biostatistician, Jonathan Mayo, who has a great deal of experience in perinatal biostats and has worked with many of us on projects over the years. Will be joining us full-time, and his start date will be October the 18th. So welcome, Jonathan. And our fetal therapy symposium is on track. We've decided to go virtually on that. It'll be from Tuesday, November the 9th, from 5 p.m. to 8:30 p.m. And I think will really be an exciting launch under the Dunlevie Center for this important domain of our research. And yes, Virginia, thank you in the chat for pointing out Angela's incredible support for your work. Our next center meeting is on Thursday, November 11th, and it will be on basic science, on the area of basic science discovery. And the next slide, just here to show our, oops, can you go back? There you go. This is our center event on fetal therapy. Great lineup of speakers. It's a multidisciplinary symposium. Really update the most up-to-date basic translational and clinical research in this area. And so I hope all of you can join in. And I think with that, we will move on to our speaker for the day, who is one of our new faculty, just joined us recently, Dr. Deirdre Lyell. Well, Deirdre has been with us since she was a fellow and has been a star from day one, rising through the ranks to full professor, director of our fellowship program, medical director of labor and delivery, director of the placental disorders program, among many other activities, and most recently Dunlevie Endowed professor, our first endowed professor under the Dunlevie umbrella. And Deirdre will be talking to us about topics within the population health area that she is focusing on now in this new chapter in her career. That is not Deirdre, but anyway, so Deirdre, why don't you take it from here?
Great, thank you, Yasser, for that introduction and also for your mentorship over the last 20 years that I've actually been at Stanford. I'd like to say it feels like it's just brand new, but it does feel like 20 years in the best possible way. And for your leadership, excuse me, of this incredible program. And then I'd also like to acknowledge and thank Elizabeth and Bruce Dunlevie for their generous gift, just foresight and investment into ultimately making the world a better place for pregnant people and their families. And I'd like to also, this is from the center website. I don't know if you guys have seen it yet, but these are the four domains within the Dunlevie Center. And this presentation falls within the domain of perinatal epidemiology and population health. And here on our website are the joint faculty of perinatal epidemiology and population health within the Dunlevie Center, who also have appointments in obstetrics and gynecology. We have many other collaborators as well, many other important epidemiologists and experts who are not yet shown here, such as our OB anesthesia colleagues like Alex Butwick, who's an epidemiologist and expert in obstetric hemorrhage, and then so many others from around Stanford. So please stay tuned. We're lucky that we have an extraordinary depth of knowledge and expertise just right under the Stanford roof to really help to address the issues that we face in perinatal epidemiology and population health. And the work I'm going to present today, I'm co-leading with Dr. Elliot Main, who is the founder and director of CMQCC, or the California Maternal Quality Care Collaborative. And it's work that's done through CMQCC, and it's an honor to be able to work with him. I feel very, very blessed in that role, and also feel very humbled. A lot of the work that I'm going to quote today is really work that he's done and led to this point where we can even start with one of the projects that I'm going to be presenting. So with that said, I'm going to talk again with work that several of us who are already on the Zoom presentation have also been working on. That's related to iron deficiency anemia in pregnancy, and really focus on why this is such an important problem to understand and to solve. So first, some background. I realize that there's a pretty wide, a lot of people on this Zoom call from a lot of different backgrounds. So I'm just going to start with the very basics. What is anemia? It's essentially when you don't have enough healthy red blood cells to carry oxygen to organs. And it's really very common. We know that it's seen in about 30% of reproductive age women. And the World Health Organization actually is estimating that globally, more than 40% of women have anemia. And there are tremendous regional differences in rates of anemia. It definitely does reflect things like nutrient deficiencies, socioeconomic status, things like that. But among all different types of anemia, iron deficiency is the leading cause in all environments, regardless. And I want to turn your attention now to the graphic on the right. And this just gives you a sense of how much iron is needed during pregnancy and why this might be a tremendous problem during pregnancy. Oops, my pointer is not working very well, but if you can look at the outermost sort of cardinal line, this is just a normal anemia or normal iron requirements, about 1 milligram per day for a person. And during pregnancy, maternal blood volume increases by about 50%. So that demands a huge amount of iron. We know that iron is critical to formation of red blood cells. So, you know, maternal blood is going to increase by so much that you need a lot of iron to just sustain that, or mom becomes quickly anemic, and that has consequences that we'll discuss a little bit later. That demand for iron increases really substantially throughout the pregnancy. Some of it also comes from the fetus that's growing. It has its own blood supply, as well as the placenta. But demands get tremendous, highest at the end of pregnancy. And actually, before I get to that, the iron does a lot of things. It's going to support normal growth and development of the fetus. The pregnant person needs also a pretty good buffer for bleeding that's going to occur at delivery. So we can screen for iron deficiency anemia, and we can treat it. So typically this, screening occurs with just a complete blood count that's done at the first pregnancy visit, then again at 24 to 28 weeks. But practices and opinions for what to do after that really vary. There are practice bulletins that make recommendations. There are definitely differences in opinions on what is the best way to approach and screen for anemia, even among experts within our field. Now, let's talk a little bit about the consequences of anemia in pregnancy. So delivery, as I mentioned, is the time when anemia is going to put the mother at the greatest risk. We know that blood is critical. We know that women who enter delivery who are anemic have much higher rates of maternal blood transfusion, sepsis, cesarean delivery. That iron deficiency anemia itself puts the mother at risk for severe maternal morbidity and death. And then persistent anemia has consequences beyond the delivery that can really affect people for the life course. One area that doesn't really receive a lot of attention is cardiovascular disease, which is the leading cause of death in this country. And we know that anemia is an antecedent to that, and certainly anemia at delivery can lead to longer term consequences there. So I mentioned delivery being that really important time that puts the mother at greatest risk. We know that blood delivers oxygen to critical organs, including the brain and the heart. And a postpartum hemorrhage can be rapid. The blood flow that normally goes to a non-pregnant uterus is about 4% of someone's blood supply, whereas when someone is pregnant, it increases about 5-fold. So 20% of the blood supply goes to the uterus. So you can imagine if something happens that sometimes does at delivery, the uterus may not clamp down properly, a condition called uterine atony. Maybe there's a laceration or a cut through one part of the uterus, and maybe even cutting a vessel. Someone can bleed to death actually as quickly as within 5 minutes. So it is a tremendous concern, a problem. We know that anemia itself is associated with a much higher rate of maternal morbidities, as I mentioned, and then all the complications that are associated with maternal mortality as well. And so just as we wouldn't drive into the mountains, say with a tank of gas that were low, or around here, I should say, charge that's not, your car's not fully charged. It's not really ideal to go into a delivery with a tank that's not really full. And the impacts are actually seen with the baby too. And this was an area that I really find interesting, in that I've gone through obstetric training. I've taken care of lots of women who are taking care of, who are growing newborns, growing fetuses, and really have not come across all the implications for the fetus, the newborn, and the child, and kind of life-term implications that iron deficiency anemia in pregnancy can have on the future until this project. We know that maternal to infant or maternal to fetal iron transfer happens during pregnancy. It's really critical, and it's really key for about the first 6 postnatal months. Most of this iron transfer happens in the 3rd trimester after about 30 weeks, and this is a time where there's maximal maternal iron absorption. We know that the GI tract upregulates iron absorption receptors. And this is also why prematurity itself can worsen iron deficiency anemia. If a newborn comes in the world at, say, 30 weeks, they haven't received that iron loading. And then this can lead to much longer term issues, because it's really hard for newborns to really make up that iron deficiency. We know that there are other conditions during pregnancy that can worsen maternal or neonatal iron deficiency, things like hypertension, cigarette smoking, glucose intolerance, and diabetes, which we do see a lot of, especially with the rates of obesity that we have in our population. And it seems, though, the good news in this story is that it seems that it takes a pretty large amount of maternal anemia, moderate to severe anemia, to really compromise neonatal iron status among term newborns. So it's different among preemies for reasons I've mentioned, but it does take some pretty severe iron deficiency anemia. But with that said, we do see this a little bit more than we should. As I mentioned, neonatal anemia is difficult to reverse, really due to the poor neonatal and GI absorption of iron. There are also several associations with iron insufficiency. We know that it's associated with an increase in preterm birth, about a 2 to 3-fold increase. The reason I say association is we don't know if it's a cause or if there's some kind of confounding variable, something else happening that increases that risk. But there are data to really suggest that there may be a causal pathway as well. But things like low birth weight, being small for gestational age newborns, we know that in animal studies, low 3rd trimester maternal iron intake can result in altered neonatal brain structure and less complex dendritic structures. These are structures that are important for complex task processing and things like that, which may explain the next couple of slides. That in the newborn, neurodevelopmental abnormalities are seen as early as the newborn phase to 2 months of age. And these include things like poorer recognition, memory processing, slower processing speeds. And this continues in infancy and toddlerhood. We know that those who have low iron stores at about 9 months of age, in the short term do show slower processing speeds, poor motor function, increased social dysfunction, and then in the longer term, increased rates of depression and anxiety. And even when you replete these stores, so if you start with low stores, even when you replete them, so low stores that were identified in the umbilical cords of newborns, when they were repleted, there was decreased recognition memory at 3.5 to 4 years of age, again, regardless of the correction. I find that really stunning. There are other associations that have been reported. Again, these are very difficult things to study in a population, but there may be greater risk of autism, schizophrenia, and difficulty in planning and attention at the age of 10. So I just wanted to give you that background because, again, I think, it's important enough to do this work for maternal well-being, but I'm just really struck by the impact that all of this can have on newborns. So now let's come back to mom. There is a pretty significant racial disparity in anemia, iron deficiency anemia at delivery. When we consider birth admission, Black women have 4-fold higher rates compared to white women of iron deficiency anemia, about roughly 27% versus 7%. You can find variable numbers roughly around these percentages. This disparity is also seen among Hispanic and Latinx women compared to white women. It's about 1.5 to 2-fold higher. And anemia has been increasing among all race and ethnic groups. I'm not entirely clear why. It may be due to our very high rates of obesity and things like gestational hypertension and diabetes that go along with that, as I alluded to earlier. But we know also that anemia can exacerbate other disparities. That Black women we know are 3 to 4 times higher to die in childbirth, for example. And you can imagine if you go into childbirth already anemic, and a couple of things happen as they do. That if your tank is pretty full, you can tolerate them. If that tank is empty, then or near empty, or even just low, there's less of a buffer to tolerate some of the events that can happen just around giving birth. We know that severe maternal morbidity risk, which includes transfusion for Black women, is about double that for white women. And this is true even after you adjust for sociodemographic factors, so insurance status, education, and also medical comorbidities. And we know that SMM increases the risk for death. So you can imagine how all of this may contribute to a lot of the disparities that we see both in maternal mortality. We know that it's much higher among Black women, but also in severe morbidities. About half of the cases of maternal morbidity and mortality are considered preventable. I think that's very humbling. Iron deficiency anemia is entirely, or I shouldn't say entirely, iron deficiency anemia is preventable. So all of this begs the question, so why is there still anemia after 7 or more months of prenatal care? I can't quite say this the way Elliot Main, the guru of quality improvement, can. He has a lot of angst in his voice, but I think it's an important question. And it really, we give prenatal care. We know that prenatal care helps, that a lot of people who come in for prenatal care, who are receiving prenatal care throughout the pregnancy, are still arriving at their birth admission anemic. It's true when you look across populations. It's true in local areas. We think there may be several reasons for that anemia is under-recognized as a problem by providers and by patients. There are variable approaches, as I mentioned, to evaluation and treatment of anemia. And treatments are also not easy to take. So can interventions help? Do they reduce disparities? Is there something that we can do? And the answer here is yes. Large-scale quality improvement interventions work to improve maternal health and to reduce disparities, at least in the hands of the same QCC. And here's one example. They implemented a guideline really for what to do about maternal hemorrhage, and implemented this guideline in a hemorrhage bundle that included things like preparedness for hemorrhage, drills, a bundle of best interventions, debriefs, things like that. And about 1.3 million births in California were examined, and they looked pre and post intervention. And then they also looked at discharge diagnoses, procedure codes, and birth certificates. All of these are linked within the CMQCC's Maternal Data Center. And fairly remarkably, the CMQCC hemorrhage safety bundle reduced hemorrhage-related SMM, severe maternal morbidity, by more than 20%. For a QI intervention, that is actually quite amazing and makes differences in a lot of people's lives. But let's look at the racial and ethnic inequities. So the blue bars here represent severe maternal morbidity rates pre-intervention, and the kind of orangey brown bars, that's what they look like to me, are post-intervention. And now look at the differences in the blue bar, sort of pre for Black women. The rates were 28.6%, so highest among any group here. But then look what happened post-intervention. If you look immediately to the right, they really decreased tremendously, to the point that if you look at the difference for SMM between, say, Black and then to the right Asians, there was only a 0.1% difference. So really, this is an intervention that was able to close that tremendous gap in inequities. When we look at severe maternal morbidity and exclude cases of transfusion, transfusion is one of the definitions of, or qualifies people for having severe maternal morbidity. But if we take that out, then we're looking at other things such as, who was septic, who had a pulmonary embolism, other pretty significant problems. You also see just a tremendous reduction, again, comparing the baseline numbers to the orange brown. There's a huge drop in, particularly among Black women, and you see it among other underrepresented groups as well. So we know that putting toolkits in place really can reduce disparities, and we know that bundles can help. And essentially, these are guidelines for how to kind of be prepared, education, drills, practice, and really recipes for how to do something when things go bad. And it really helps to, I think, level the playing field among different hospitals, different levels of care, different training. And this approach may not make them go away entirely, but it really can help to reduce them. And James Reason described the Swiss cheese model that I'm sure many of you are familiar with. It's a model of accident causation, kind of prevention, and it puts a lot of measures into practice, really in order to prevent them. And we do put this into practice really every day within perinatal care, and we do this in order to reduce the chance of the perfect storm, and that's that everything lines up and the arrow gets through this Swiss cheese and it leads to perinatal morbidity or mortality. You didn't prevent it, but these are things that we have, every day. I know that Janine Johnson is on this call. She's our quality nurse in the Johnson Center. There are a number of people on this call who work, Yasser, who work hard every day on our L&D in order to prevent bad things from happening. We report near miss events. We implement on our labor and delivery CMQCC quality improvement interventions. And these are really quite important, but for our anemia work, we're really shifting the focus a little bit upstream with a focus on reducing who comes into labor and delivery with anemia at delivery. So I'm going to ask that same question again. We know that Black women have 4 times and Hispanic women have about 1.5 to 2 times the rate of iron deficiency anemia at delivery admission compared to white women. And why, again, should there be so much anemia after 7 months of prenatal care, 7 or more months of prenatal care? And this is even among people who, receive the highest level of care. And it really tells us that current approaches are not working. We have a problem, and there's no study out there that really considers the perspectives of Black or Hispanic and Latinx women on iron deficiency anemia in pregnancy. So we proposed a solution, and this is really 2-pronged, and that's to work with patients and communities to assess their understanding of anemia and iron treatments, And then to design better messaging, better education out there of why this is important, why it matters, and better approaches to treatment. And then the other prong is to work with providers to create and implement patient-centered solutions. And this is, we have a study that we have been meeting together as a group for at least a year now, the anemia community engagement to reduce maternal inequities from anemia. It's the anemia study, a little bit easier to say. And again, it has two components: identifying patient-centered solutions and then identifying provider approaches as well. And for this project, we received a grant from Spectrum. Spectrum is the Stanford Center for Clinical and Translational Research and Education in order to do this work. And we've been partnering with the Black Wellness and Prosperity Center in Fresno. This is founded and led by Shantae Davies Balch, and we've worked with her for more than a year. And she's forming an anemia community leadership group with leaders from WIC, Black Infant Health, and others, and working together with a qualitative researcher, Dr. Susan Perez, to assess knowledge and experience among Black and Latinx women, ultimately to develop patient-centered tools. And we will be, doing a number of listening groups, or Shantae and these groups are going to be leading them. And again, Susan Perez is a qualitative researcher, and she's going to basically be analyzing kind of what comes out of these qualitative experiences, really to try to identify what do people care about. How can we, what kind of education materials would resonate with people? How can we consider patient satisfaction and experience as well? And this is the grant. And I mentioned there's also the clinical end of it. So the clinical collaborative leadership is led out of Stanford, and we're doing this work simultaneously. We're trying to identify clinical protocols and tools that are focused on a common way to define and treat anemia in pregnancy. And we've identified several barriers from clinicians' perspectives too, including the very heterogeneous approach that I had mentioned already. Some of the treatments that are best as well are very difficult to access. We have a difficulty getting patients, for example, IV iron. This is what we've heard from multiple providers from around the state. There are sometimes where somebody really can't take oral iron, and IV iron might be their best bet, but it's not a simple thing. Ultimately, we're going to create a patient-informed toolkit and a bundle for evaluation and treatment of anemia that will be ultimately rolled out to the offices and clinics within our 18 participating hospital systems. And together we'll work with the CMQCC Data Center to collect data and really measure outcomes. And from other CMQCC work, as mentioned, and Elliot is going to be best to comment on this if he's willing, clinical care and health equity combined have the greatest impact. And this work also relates to other CMQCC work not mentioned here, but particularly work around supporting vaginal birth and reducing cesarean deliveries, for which Black women have a higher rate. And then finally, I just want to give a just mention and the work by Dr. Iro Igbinosa, who is our third-year maternal-fetal medicine fellow, who I've had the great privilege of mentoring for a number of years. And on a local level, rather than a population level, she's been leading an important randomized controlled trial of IV versus oral iron during pregnancy in order to identify really what corrects anemia best at the time of birth admission, what changes hemoglobin the most, what changes rates of blood transfusion, adverse events. We are assessing also compliance with medications, particularly oral iron, and then things like severe maternal morbidity and severe neonatal morbidity. We may be a little bit underpowered for some of those, but that is, those are all things that we are looking at. And with that, I would love to open this up now for discussion, questions. And I think we've got almost 15 minutes.
Deirdre, thank you so much for this outstanding presentation and highlighting your excellent collaborations and collaborators. So I think if people can just speak up with questions as opposed to going through the chat, that would be great.
And actually, before we open to questions, I should ask Elliot if you have any comments or if you'd like to add anything, because so much of this is truly your work.
Well, one of the things that came up in this process is that we're probably not just talking about anemia, but iron deficiency. And that was an important distinction both for diagnostic tests as well as interventions. And it gets to the issue potentially of why Black women have more anemia to begin with. Is it because of higher rates of menorrhagia, higher rates of leiomyomata, or other more chronic conditions that lead them to have lower amounts of iron or lower levels of anemia at the beginning of pregnancy that's not being treated during the course of pregnancy? So this is opening up additional areas for potential work through the life course. But this is one of several projects we're doing now that has strong community engagement, moving to the outpatient arena, as well as working in the hospital for acute events like hemorrhage. Thanks, Deidre.
Yeah, I'm going to jump in. Your work is absolutely fantastic and has such, it is already impactful, but has such potential for even greater impact. My question's a little broader. And I'd love to hear more about some of the barriers that you think Black women in particular have to correcting iron deficiency anemia, either at the start or through the course of their pregnancy. And then how can we find culturally and resource appropriate ways of treating this, not just in our big city here in Palo Alto or San Francisco, but in rural United States or across the globe?
Yeah, I think that's a great question. It's a question for which we're looking for a lot of money to help us fund some of this work too. So
I'm helping.
thank you. But that was the impetus for the really this community engagement work that you're right. I mean, we're not, we do not have a large Black community here. We have a very large Latinx community, and anemia rates are higher there as well. But it's not clear. Anemia, we know, goes undertreated in all populations, but particularly in, Black women have the highest rates. And as Elliot said, we don't quite know who comes into pregnancy with lower, already with some iron deficiency. Eero, Igmanos, and I looked at some the California state data, and we postulated maybe it's because we know that Black women have more uterine fibroids or myomas. They can lead to a lot of very heavy periods and menorrhagia, and maybe they come into pregnancy, much more anemic. And we looked at this, and there wasn't really a significant difference in the rate for Black women who have fibroids and anemia versus not. So that probably isn't the answer. But we are looking to community groups. That's exactly why our work is with, particularly with Black Prosperity and Wellness Center and, Black Infant Health and WIC and people with lived experience. And this is an area that I think qualitative research is really very important. My background is in more quantitative research, and this is, you can look at, what you look at in numbers, but I think to really understand the nuance of why something isn't happening, I think talking to people with lived experience is really critical.
And are there different iron recommendations for Black women than everyone else or than white women during pregnancy?
So that's a very timely question. There was actually, much to a lot of our surprise, there was a ACOG and a bulletin had, and they've corrected this since, but had a different threshold for how anemia was defined in Black versus other women. And this was called out in a presentation at SMFM, an oral presentation, really kind of underscoring that if people followed this, then there would be a lot more undertreatment of iron deficiency in Black women. I think a lot of us were unaware of this and surprised by it, and they've since removed that. But there really shouldn't be differences. I don't know if others want to comment.
it underscores the challenge and the perils of establishing norms by looking at the 95th centile. You know,
Yeah.
that's what the history was here, that the 95th centile for Black women was lower than the 95th centile for white women. And therefore, those norms were established, not respecting what is healthy or not, or what is not respecting, you know, why there might be differences. And that's happened elsewhere. This is the whole creatinine story and some of the other race-related norms that are probably not appropriate that we have in medicine.
Yeah. And then Arrow, if you can comment, it would be great to talk a little bit more about the recent abstract too, and anything else. So you've done, Arrow has, this has been her major fellowship project as well.
Yeah, no problem. I was just gonna add that we have our recent abstract for SMFM, sorry, I'm post-called and like struggling to get my words out, is looking at social determinants of health and that intersection of race and anemia. And there was a recent paper that looked at this kind of intersection for preterm labor for Black women, kind of using this like, you know, kind of this more robust index by the CDC by looking at, you know, instead of your traditional way of looking at determinants of health by like insurance, et cetera. And so looking more about like poverty index, looking at neighborhoods, and that also kind of gets into some historical implications of racism and how that affects health outcomes. And so that's really promising there. And then just kind of echo what we've really learned is that that we really have to really kind of work with community groups, because there is in the non-obstetric literature where kind of just routine IV iron or et cetera protocols were given, and it actually caused harm to certain race and ethnicities. And so really just making sure that we have a lot of intention in understanding the cause before providing a solution.
Yeah, good point.
Leslie had a question in the chat. What is the increase in, is it cesarean delivery, Leslie, that for Black women? If white say is 20%, is Black 21% or 25%?
I see Elliot smiling. He is the expert here, so I'm going to pass this one to you.
So the total C-section rate in the United States as a rule has been rising and leveled off, and has fallen a little bit for whites, but it's actually gone up even further in Blacks. So the disparity between Black and white C-section rate has been increasing in the 2010s. So it's about 5 to 6 percentage points higher. That's also true for NTSV, the nulliparous transition vertex semi-standardized version of a C-section. And that's even though California is lower than most states now, it's still five-ish plus or minus 5% percentage points higher in Black women than white, though not in every hospital. There's huge variation in care among hospitals. We were just on a research call earlier today looking at this, and there's huge Black-white variation among some hospitals have the same Black-white C-section rates, and other hospitals have big differences. So it's really an interesting area, but it is a driver for blood loss in hemorrhage and transfusion to have higher C-section rates among Black women.
And Elliot, do you know, is there a bigger difference between white and Black in hospitals that have fewer Black or greater Black percentage of women?
I'm smiling again because that's one of the questions we're looking at there. It's hospitals of all types. What we saw could have low C-section rates and low Black-white differences. So it wasn't all in one category or another. I mean, even among hospitals with a lot of midwives, 50–60% midwife deliveries, there were some hospitals that had very low C-section rates for Blacks and some that had very high C-section rates for Blacks. And so the variation is just tremendous for all these parameters. There were university hospitals that did very well and others that did poorly. County hospitals that did well and others that did poorly. Little hospitals, big hospitals that did well and others that did poorly. So it looks like it's practice style or pattern that's a contributor. There were Kaisers few Kaisers did well, but a lot did not do well on Black C-section rates. Interesting to see. So stay tuned more, but the variation is astonishing. So Jean Johnson, so we get in a question in the chat box is medical populations proportionally represent CMQCC data? Ours is based on birth certificates and hospital discharge diagnosis. So we get data on every single birth in the state. We're not actively pursuing the home births right now. The birth center births, those are about 1.5% of the births in California. So we don't have OSHPD files on those, and we're focused on hospital quality improvement, but we get every hospital birth that we're focused on, that we focus on right now throughout the state. And this goes back to 2011.
Great discussion and wonderful conversation. Any other questions? If not, I just want to thank Deirdre again for this great presentation, and thank all of you for your attendance. This is so nice that we can all kind of get together regularly and go over these various areas. We'll be doing this on a regular cadence and delving deeper into each of these areas in the Dunlevie Center and onto specific projects and activities within these areas. So a lot more ahead. Thank you all for your engagement, and have a wonderful rest of the day.
Thank you.
Thank you.